The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Welcome to this week's episode of the Pediatric Lounge. With you is your co-host and co-founder, Dr. Herb Bravo. Also with us today will be Dr. George Rogu, who, as you may know, is the president and CEO of a clinically integrated network in Long Island, New York. He has used data and data dashboards to implement best practices across independent pediatric practices in Long Island, New York, with much success over the years. Our guests today are good friends of mine who I've known for many years, and I'm very proud and honored to host them today in the lounge. Dr. Rinad Beidas is professor of the University of Pennsylvania, Paramount School of Medicine, and Director of Implementation Science at the Nudge Unit. She has been appointed the chair and Ralph Seal Pfaffenberger Professor of Medical Social Sciences at Northwestern University Feinberg School of Medicine in Chicago. She will start that position September 1st. Dr. Sary Beidas, her father and my good friend, is an internist and infectious disease specialist with a master's in clinical informatics. He's also the co-author of the only published article that I have, which we published from Southwest Virginia many years ago, and I am very proud of that. You might ask why I have these three persons today in the lounge. Well, Rinad's research broadly focuses on leveraging insights from implementation science and behavioral economics to make it easier for clinicians, leaders, and organizations to use the best practices to improve the quality and equity of healthcare and enhance health outcomes. This is of paramount importance to all pediatricians who seek to remain independent, using data to improve care, implementing best practices, and proving value so that they can maintain the margins in their practices. Welcome, and I look forward to the next 45 minutes together. Dr. Rinad, what a pleasure to see you again. You've grown some since the days when I met you.
It's lovely to see you too. I think it's been a long time.
I think the last time we saw each other was in that house in Maryland on the water.
Oh yeah, Smiles was one. So it's been 8 years.
Yes. And Dr. Sary, what a pleasure to see you again, my good friend. You don't look any older. The years have gone by, but you look just as young as when I met you.
Yeah. Well, it's you remember back in the early 90s, up in Appalachia is where we met. We were up in rural America, taking care of business up there.
Yeah, that was quite an experience. So today we're going to talk about something that's always been very difficult for pediatricians. That's why we don't become internal medicine doctors, is getting people to do what they need to do to improve healthcare. And that's why many of us won't do adult medicine, because we don't want to take care of the heart attack after they've not taken their hypertension medicines for 20 years. But that also parlays or moves into what is happening in medicine. We know so many different ways of making healthcare better, and we don't get to implement it. Rinad specializes in innovation and implementation science. So hopefully we'll be able to tie everything together. How do we persuade doctors that data is not evil? How do we measure? And once we elucidate a best practice, how do we get it into the community so that patients benefit? Because at the end of the day, that's what we're all trying to do. So, Sary, you got a master's in clinical informatics, and what do we do with that?
What do we do with that? That's a very good question. So clinical informatics is mostly about the interface between computers and information, and then the physicians. The technologists, they have difficulty communicating with the clinicians in terms of developing things for them. and showing them showing them what can be done. And the physicians have difficulty in terms of communicating what they want with the technology people. So clinical informaticists, they kind of come in between and they help bridge that gap so that ultimately the physicians or healthcare providers get what they need.
So how is that difference from UX or user interface design?
So your user interface design is just those people who develop software. They're really programming applications, and users are using these applications. So typically you may have physicians that get involved, as well as others who may be using the platforms, and they work together to develop them.
Okay. And Rinad, you have a fascinating trajectory for such a young person. You are at UPenn School of Medicine for the moment. Later on, you'll be going to Northwest, right? And you study the science of implementation and are director of the Nudge Center, which is part of the Innovation Center at the Medical School of Philadelphia. Before we get into implementation science, it's a little bit interesting to me because I think of medical schools as moving very slow, as you point out on your article. It takes 17 years from when you have an idea to when it becomes clinical practice. That innovation will take 17 years, and I feel the medical schools are very slow to change. So why would a medical school have an innovation center?
Yeah, that's a great question. And we've had an innovation center at Penn Medicine for 10 years, which I think is one of the first, if not the first, I'd have to check on that, innovation center in a med school. I think we recognize that healthcare is changing rapidly, and that in order to meet the needs of patients, clinicians, organizations, that we need to have an innovation center where we can incubate the best and latest ideas, and then rapidly scale them as we demonstrate their promise. And so I think of the Innovation Center as being a really special place where people come together to think innovatively and outside of the box, outside of the traditional paradigm, to solve seemingly intractable problems and then to scale them once we identify the best solution.
Okay. And then the science of implementation, my understanding, or how I would do, because I talk a lot to patients, so I dumb it down, is what in Virginia, when your dad and I were working in rural Virginia, we called it the last mile. So you can get internet all over the country, but you can't get internet to that farm that's a mile from the road because it's not viable for Fios or Comcast. And I can tell you that I knew when I was working with your dad that the best practice was to give a beta blocker to every patient that left the hospital after a heart attack. And the studies over and over again showed that 50% of the time they left without a beta blocker. So to me, it's the same analogy, that last step of bringing the science and best practices into the care arena. And I think that's what you're trying to solve in a big picture.
You nailed it.
Okay. And
you want to come work with me? I'm all in.
Yeah, I would love to work with you. That would be a dream, right? I work with your dad first and then I work with you. So that's what you do. And there are some steps. I love your analogy of the metro. And I want to walk our viewers or listeners a little bit through that. So the first step to me would be what George and your dad do, which is to collect data.
Mm-hmm.
The second step would be to elucidate best practices from that data. And the third step would be in a control environment to find actionable data points that will change outcomes. Once we get there, then it gets really complicated.
Well,
Because
and the pathway to where you just were is also really complicated, right? In terms of like who's collecting the data, what's the evidence, what are the studies that have been done to date, who's driving that process. So it's not as simple, right? You laid it out so eloquently and in a linear fashion, but of course we know that healthcare doesn't function in that way.
correct. And then gets more complicated because, as you pointed out, this is the first time I've heard a researcher or read a researcher say this. Once you go from a totally controlled environment, double-blind, randomized studies, well-designed, it's gotten approval by a review board, is a good researcher with no biases into the system, and we go to a real clinic or a hospital or a community, then all is gone. We start all over again because what worked in a very controlled environment may not work on the ground. So that's the first challenge that we find. If we can validate the information, then we would go into trying to learn how to find barriers and find champions or things or people who would help us implement this best practice. And that's the last step, and that's the focus of your science.
Yes. Yeah. I might elaborate a little bit on that latter part in thinking about, identifying care gaps. And I think you built that into the first part of your pathway, identifying best practices that we want to deploy, doing contextual inquiry to understand why things aren't being done. And usually there are multiple levels. And just in hearing you describe the use cases in which you were describing, there's patient level barriers, there's clinician level barriers, there's team, clinic, organizational, health system, and then outer setting barriers, which include the broader socio-political context, as well as facilitators. And then we want to design our implementation approaches to leverage our kind of diagnostic process of what might be getting in the way, and then measure proximal outcomes to implementation, such as, penetration, how many patients are getting the thing they should get over the number eligible, or how well a clinician does something, as well as the patient outcomes that we typically spend most of our time thinking about in, effectiveness and pragmatic clinical trials.
Okay. And then, George, you were able to get a bunch of silos together into one dashboard that collects data. How did you sell the physicians data? Because when I talk to physicians about data, the first thing they say is, I don't need to measure. I'm a great doctor. I run a tight ship.
Yes, they all say that. I think most, especially pediatricians, they do the right thing. They do the quality metrics. They don't even know they're doing it. The problem is the technology, all right? They need to have something easy, because doctors are busy people. They're busy, saving the day. They can't be bothered with checking little boxes. And, when they went with the EHRs, that's what they mandated. Check off these little boxes for very little benefit or outcome. Now it's fast forward to population health. And we're asking these busy physicians to do more stuff. Like you guys say you do it in controlled environments and this and that and the other thing. You formulate things, you make plans. You know what? It's great because you guys work in an institution, in a place, but we work with people. We're like the Marines. We work with people. All right. And you're asking the physicians to do things that they don't see as maybe immediately important. And it's just intrusive to their way of life. And then the computers, some of them are pretty clunky. You got to get the data out. They don't know how to get the data out. And you have to put it somewhere. So it has to be non-intrusive, has to be easy to use. It has to be in your face without thinking. And then you have to be able to pull it out pretty quickly. And then you have to make use of it to give it to people back at the institution level to make sense of it,
Sary, from your experience and your master's, How do you sell? How do you make it more palatable to physicians to accept data?
So Herb, my experience may be a little bit different. Uh, from my work in the Army from actually over 15 years ago, they started developing chronic disease management kind of places of practice within the Department of Primary Care. And what you had is you brought some extended providers, such as a pharmacist, such as nurses, PAs, and they actually ran that show for the things such as the HEDIS measures, your A1C, your asthma, peak flow meter results, your LDL results. Did they get a mammogram? Did they get a colonoscopy? So what we found is that physicians are horrible at keeping track of these things, not because we don't want to. It's because, just like George is saying, it takes too much time and it does not fit within our model of practice. So when you get these other people and have them develop a population health clinic, for example, or have them just track these HEDIS measures, and automatically they can do the ordering without actually even asking you, the physician, that kind of works best. So it's really outside the context of the masters in informatics or anything. It's really, how do you help people achieve what they should be doing without imposing on their time, by seeing what others, how could they help you to, get to your goal.
I'm really hearing, I think there's a lot of alignment among the three of us in terms of how we're thinking about things. It's thinking about how to make it easy for clinicians to do the right thing at the right time with the right patient. And when I think about that, I think about what George raised, this idea that clinicians are humans and they're working so hard and they're so busy. Now within the context of COVID, there's this incredible stressor that's been added onto an already pretty stressed system. And that as implementation scientists or folks who are trying to engender change, which all three of us, all four of us are trying to do, it's really important that we make it easy through principles like changing the choice architecture and the electronic health record, to offer prompts and reminders to make things easier for clinicians, to take effort off of their plate, like you're describing, by triaging to somebody who can set an order and do the population health management. And so, those principles, and then to work things into workflow, right? A lot of times we ask people to do things that are outside of their workflows, and then they never happen because they were not designed to be incorporated into regular care. And so, I just want to say that as a researcher, and I am, at the end of the day, a researcher, I think the true test of any of these ideas are in the real world, under real world circumstances. If we can make it work in a pristine environment, that doesn't really mean anything to me, because we're not actually having impact and affecting children, families, adults, whoever your patient population is.
That's very nice. Thank you. Sary, I'd like to touch on this because change is very difficult for any organization, for any human. And it's also very difficult for business. And I know you're an enthusiast of business journals. What is referred to as the burning platform in the business world?
So I think you should direct that question to Rinad, because she is much more knowledgeable about that and can actually give you a. So please go ahead, Rinad.
No, don't pun it to me. I want to hear what you want to say.
I want to.
You have to explain the concept to me actually a little bit more.
Okay, so the burning platform comes from the oil rigs. And so change doesn't really happen in a human, in an organization, anywhere, until you see a fire on the platform. The helicopters can't land. You got nowhere to go. So your choices are throw yourself in the water and hope you survive, or let the fire catch you and kill you. Not a great choice, but that motivates change. And you see it in the diabetic, you see it in the hypertensive. Once they cut one of their toes because of poor circulation, they want to manage their diabetes, but it's too late. Once you have the heart attack or the stroke, then managing your blood pressure is important, but then it's too late. And so until people feel the pain, they don't seem to want to change.
So I'm not, I have a slightly different perspective about that. So not everyone feels that way. So some patients will actually, once something happens, such as you amputate something because of their diabetes that is uncontrolled, they will become compliant and adherent to their medications and their food and exercise, etc. But there is another group of people who actually don't want to and continue not to change or want to change. So I think the question is much more complex, Herb, and I think it's because we are people. It's not a simplistic, let's have the machine, the machines can help us, but again, it's only to a certain extent. If the individual does not want to change, I don't think we've understood really what is going on with them and what they want. Some people, in my clinic, some people will tell me, hey, I'm done. It's okay. You can let me go. And so I don't know what the exact answer is, but I think the scalability of implementation, the work that Rinad is doing, this has something to do to help us actually identify the answers. So I'm not an academic guy, I'm a clinical guy. And I think I want the academicians to help us trying to understand that and get us to where we need to go.
I think what happens in the clinical world is you have those that want to and those that are impossible to change. But we as physicians or in the medical community or the academia world, we focus on those that don't want to change, the really hard stuff. And you put all your energy and your resources into that, you will probably fail. I would just put into ones that want to change. You'll make an effort and make those people change. And then once those people start changing, I think the other ones that are against it probably will, flip and change their mind also, I think we waste too much resources on the impossibilities. Go for the low-lying fruit.
Yeah, it's difficult when it's a kid and you see the trajectory.
Yeah,
Yes,
it's true.
Yes, Rinad.
I think it's a really interesting question. And from an equity perspective, I think that we have to be distributing our efforts across the spectrum, because understanding why people do or don't want to change is kind of at the core of what you're saying, Dad, right?
That's right.
Like,
that's right.
You need to be able to, and that's true at the patient level, but it's also true at the clinician level, right? Because most of my work focuses on, and for, I'm a PhD, I'm a psychologist, I'm not a physician, but most of my work focuses on changing clinicians' behavior within organizational constraints. And so, we really need to understand and partner with, whether it's a patient or a clinician, what's getting in the way of being able to do that thing. And I'm always really careful to not think of people as being resistant or not, too hard to change, because if you can understand why people are having a tough time with something, then and partner with them and find a shared mission, you can go so much further.
You probably could.
Yes. And so, Rinad, what is behavioral economics? How does it play into not only changing the physicians and organizations, but the patients and the adherence of these best practices?
Yeah, so I'm more to behavioral economics, and I came to it. So I've been doing implementation now since about 2005, so around 17 years. And, the field was really nascent when I started doing this work. I came to it actually as a clinician. I kept seeing my patients come to our research-based clinic, pediatric anxiety. They had gotten a bunch of treatments out in the community. They hadn't gotten better. And they came to our clinic where my mentor at the time had developed this evidence-based practice for pediatric anxiety. It's a type of cognitive behavioral therapy. And the kids would get better most of the time, right? And so they'd say to me, I thought that, I got treatment before, it didn't work. I didn't think psychological treatment worked. And so I started to ask myself, when I saw this observation happening over and over again, why not? why don't clinicians in the community offer this evidence-based practice? So I went where most people go, which is they think, oh, it's because people don't know how. Have you ever had that thought like, oh, people aren't doing this thing I want, and so it must be because they just don't know or they don't know how? And that was a naive starting point. But actually, if you look at the literature, that's where most people start.
Yes. So that's where you started.
So, yep. So I started off with this idea that it was a knowledge gap. And then I did a big study training clinicians. And then I spent a lot of time in the public behavioral health system in Philadelphia, which is actually a real innovator and leader in delivering, mental health services in the public system. But what I came to understand was the context that clinicians were working within, and that often when we were asking them to do evidence-based practices, it was in a very stressed environment, and we're just asking them to do more. And the assumption there is like, if you just work harder and you learn this thing, you'll be able to do this. And I realized that behavioral economics had a lot to offer, because what it does is acknowledge, A, that humans are humans, and that we are predictably human in the way that we make decisions. And it also really focuses on how to change the environment to make it easier to do the right thing. So have you ever walked in a cafeteria and seen a bag of chips at the food register?
Yes.
You grab the bag of chips. Well, what if that's an apple, right? So you grab the apple. It's the same concept of how can we create the environment for clinicians to make it easier for them to do the right thing. And I was really influenced by a study that a colleague of mine did, where they looked at a change that was made in the electronic health record, where they changed the default in the EHR to be from prescribing name brand drugs to generics. And overnight, the compliance with prescribing generics went up to almost 100% for every drug but Synthroid, which you all know, a drug that physicians prefer to prescribe on formulation. And so essentially, clinicians could change it if they didn't agree with the default, but it just made that behavior much easier to shape. And so I started to think to myself, implementation science, we're often throwing the kitchen sink to try to figure out how to change behavior, but we should be applying these concepts as the first line of defense always, and then layer on additional more costly, less scalable approaches for priorities. And that's where this idea of a learning health system is really important. And, I'd be really interested to hear from George, how do you decide what to measure in the dashboard? You have a sense of priorities, right? And those are the things that you're really trying to shape behavior around. So I'd love to hear that, because I think that prioritization piece is often left out of the conversation.
Right. So the way we do it is, you're asking doctors to do things. They're already, there's a list of HEDIS measures for pediatrics and for adult medicine. They're pretty darn simple. Getting it done and measuring it and presenting it is the complicated part. So, people come in for their vaccines, you tell them to get their vaccines, they come in for their checkup, you measure, whatever is your lead testing or whatever it is. I should not be involved in that. I should just do my daily routine, and it should flow from the EHR to something, which is a centralized dashboard, which houses all the data from different practices with different EHRs. Because usually what happens is with institutions and things, they say, well, we can't measure this unless you come on board to our clunky EHR. And doctors resent that, and they won't do that. So they won't do anything. So you have to pull it through some universal language, mix it up, and give pretty pictures, because that's what doctors want, pretty pictures. They don't want spreadsheets. They're not spreadsheet gurus. They want the end result because they're too busy to look. So they need it red and green. Green is good, red is bad.
George, could you share like one or two things that you measure across the CIN?
Well, a difficult one to measure is the HPV, the human papillomavirus vaccine, because there's a lot of apprehension to getting that vaccine. And it seems to be more so now after COVID for some reason. Unfortunately, people who come up with these criteria, they don't see people. You got to talk to a mother. You have to, it takes time to convince them. And you can't have a hard stop at 13. It should be a little bit longer, but I can understand why they want it at 13, because the immunity is better when they're younger. But just finding change and finding ways to get doctors to do it and presenting, that does a good thing. So if you do good things, you make good medicine.
So the HPV is interesting, right? Because
Mhm.
we know best practice is to vaccinate boys and girls.
Right,
There's two vaccines, and that will basically eradicate all cervical cancer in the country.
correct.
So there is no justification not to free a woman from cervical cancer, none whatsoever.
But that's so far into the future that the mother doesn't see it. I thought that the
Yeah.
best marketing piece that the company had done was they produced these videos where they show a young adult talking about, you know, Mom, I have cervical cancer. When the doctor told you about this vaccine when I was a teenager, maybe you just didn't know.
Yeah,
They put
and
the guilt on. It's interesting.
many of the things that you measure are dictated by the government or the
Yeah,
payers.
yeah.
And the standards are set by them, whether they're realistic or not.
Well, what I don't agree with is the people that do the research or whatever, the HEDIS measures, they have hard stops. Okay, like for example, they want to get the combo 2, combo 3 vaccines, have a certain amount of vaccines by your second birthday. Well, we discovered a workflow problem that we had in our office where some vaccines you would give it to or catch them up at 2, but if you do it at 2 years and 1 day, you failed the measure. There's no window. They don't have a window. You have to have a window, and then you fail a big measure. You fail a big measure, there's some monetary repercussions on it.
Well, to me, talking to Dr. Cooper was, I know James, Dr. James was
Yeah,
sad that in Tennessee, the average population receives only HPV 35% of the time.
yep, that's
And he's been able to get it up to 70%. But that still means that 30% of his patient population is at risk for a disease that we should be able to exterminate, like polio.
but because of his efforts, whatever they may be, he is no longer, he had only 30%, he lost 70%. Now he has 70% and he lost 30%.
Yeah.
Eventually he'll catch it. You'll never get 100%.
No, but it's sad. I mean, that's a lot of people that could be
Yeah,
helped.
but if he did nothing, it would be even sadder because you lost 70%.
Absolutely, absolutely. But
So
still,
let's
it's sounding
focus on that one, not that
that
other one.
that
To
Tennessee's
me,
average is 35%. Yes, Rinad.
this is one of my favorite implementation gap examples. I'm glad you brought it up. Because first of all, and George made this point, there's this issue of temporal discounting or the future, right? Like a lot of the use cases we think about, like, taking your cholesterol medicine or getting an HPV vaccine, you don't see the outcome for many, many years. And as humans, from a behavioral economics perspective, we're notoriously bad at kind of understanding the long-term future risks, and we kind of focus on the present and the now. Then there's intervention characteristics. So it used to be that the vaccine was 3 doses. I believe that it's 2 now. But that's tough. That makes it harder. That introduces friction, right? Like I have to take my kid twice to get their shot, not just once. Then there's parent factors, right? A lot of parents feel uncomfortable talking about the sexuality of their young child related to HPV, and there is this kind of sexual stigma associated with it. Then there's clinician factors. We know that some clinicians don't feel comfortable or might not have self-efficacy around talking about this with parents. And then there's organizational factors, like the great work George is doing. Is the organization tracking, how many of their clinicians are offering and getting parents to agree to the vaccine? And so you can see how these concepts that I've been talking about a little abstractly up until this point are all baked into what, this great example that you all just offered.
Yes. And then I'm going to touch a little bit on mental illness, because in pediatrics, we didn't really see an epidemic in the US of COVID, but we are certainly seeing an epidemic of mental illness after COVID in children. And talking a little bit to Sary, he says it's the same thing in the adult clinic. The amount of anxiety and depression and bipolar is overwhelming. The poor people and minorities don't have where to go for therapy when you do diagnose them. And internists and pediatricians, we're not trained in cognitive behavioral therapy. So we don't have anything more to offer than a prescription for Lexapro. Why, and I know, Rinad, you studied this issue, why is it so difficult? In my mind, anxiety We have a concept in pediatrics. It's called the allergic march. The kid will start with a runny nose, then they'll develop eczema, then they'll start wheezing. And in my mind, anxiety develops a march into depression. And if we could stop the anxiety in young kids, maybe we can really make a difference on depression and mental illness going forward. We know cognitive behavioral therapy works. We know there's people like John Kabat-Zinn in Massachusetts who's developed a mindful / cognitive behavioral therapy approach. It's a 6-week course. It's been implemented in England after you've been treated for depression, and these things work. And yet, it's so hard to find a cognitive behavioral therapist in the community, even if you got $250 a week to spend in your child to do this. Why are we so far behind?
Because
I
we
can tell
haven't
you the
invested.
answer.
Oh, go ahead,
Nobody
George.
pays. The insurance companies don't believe in it and they don't pay for it. So nobody does it. And the ones that do it are out of pocket. It's sad.
So I was going to say we have not developed the mental health infrastructure needed, and we do not pay for the services in a way that would produce an environment in which it would be easy to access and receive high quality care for all people in the United States. And I do think we're in a moment. Listen, if we can't get it right now when the numbers are skyrocketing, and I just read this New York Times article about how the emergency departments are boarding adolescents who are suicidal because there's no psychiatric beds. If we can't get it right now, I honestly don't know if we'll ever get it right. I'm an optimist at heart. And so I do think that this is a moment. President Biden announced, that there are going to be significant resources for mental health, for building the mental health infrastructure. We have to think outside of the box. There are great computerized CBT programs that could be made more broadly available. But also, why isn't mental health a core part of school curriculum?
That's a very interesting question, because it brings me to one of your co-fellow researchers at UPenn, Dr. Marty Seligman, who is the father of positive psychology and one of my heroes. And he talks about a simple exercise. He calls it the three thankful prayers, or the gratitude prayer, where you teach young children in an early age to write in a journal 3 things that they're grateful for every night before they go to bed. And he's got good data that very simple intervention that can be deployed across every school in America without much of a cost really helps decrease anxiety and makes these kids more resilient. Yet I don't hear much talk about deploying that. Why?
Our system is really focused on serving people only when they become sick. And I think that's true in the physical health arena as well. And so, there are many colleagues of mine who have been doing prevention work in the schools for many years. Schools are where kids spend the majority of their time. There's no excuse for why, socio-emotional prevention related curriculum are not more widely deployed in a really consistent and even way across our country. But I also want to say, Herb, that that exercise is wonderful. And I'm not actually familiar with it. I'd need to look at the evidence, but I believe that could be effective. But it's going to take more than that. This year, the Surgeon General, the American Academy of Pediatrics, almost all the pediatric organizations have declared an emergency in the mental health of our country for young people. They're facing, we have almost 200,000 kids at last count who have been orphaned because of COVID. There's climate change, there's school shootings. I want to be really clear that doing a mindfulness exercise at school and doing that at scale is not going to solve the problem that we're in right now. We really need to develop infrastructure at every level, including universal prevention, and then addressing the needs of kids at risk, and then the specialty needs of kids who are now at a place where they have a diagnosis. We need to invest in it. We need to invest in the workforce, and we need to think outside of the box in terms of how technology can support their care as well. But technology alone is not going to solve that. We've seen thousands of apps be developed that don't have any evidence base. And we know that people engage with that technology once and then don't use it again. And so this is going to need to be a person mediated solution, but technology can certainly be helpful.
Could you say that one more time? A person.
A person mediated solution.
Okay.
Yeah,
I
people
like,
and relationships.
yes,
Yeah.
I like that. That's at the core of what this podcast is.
Yeah.
You need a conversation. You need to develop deep, lasting relationships with your colleagues, your physicians, your communities to really make a change. No piece of technology is going to solve no problem. It's just one more tool. And so I wanted to talk about one more concept because it's really important for me, Rinad, and that is the concept of neuroplasticity, the ability of the brain to change beyond 7 years of age. When I went to medical school, we were told the brain and the lungs stop growing at 7. What you don't get right in your brain by the time you're 7 years old, too bad. What's the science behind that today, Rinad?
This is not my area of science. So what I'm sharing with you is more just me kind of keeping up with the literature and knowing what's going on. But my understanding is that the brain is highly malleable. There have been some really interesting studies that have actually shown that after kids get CBT, there's changes that go on in the brain. And that's the extent of which I could describe it. That demonstrate that the brain is changing in response to cognitive behavioral therapy, which is, I think, fascinating. So I think there's so much more to learn, but my mental model is that the brain is highly malleable until we are no more. But that is based on my beliefs and not necessarily science that I've conducted.
I think you're right that they have shown the same thing in college students that go through a small exercise and meditation. They are not super meditators like John Kabat-Zinn or the Happy Monk Burchard. They're just regular kids in college. They go through a small meditation exercise, and then they do functional MRIs on them, and they see the frontal lobe lights up in this very small amount of time. So one would think that the same thing would happen in kids after proper cognitive behavioral therapy, which is really uplifting and optimistic. I want the listeners who are not doctors out there to know that you can change and that you can't go from an anxious, worrying mind to a happy mind, and that you can get help with depression and other mental illnesses so that you have a happy, functional life full of pleasure and family and good things that you deserve. So I want to go a little bit more into something that I was very interesting in, and I loved your YouTube talk. It was about gun locks and the prevention of suicide, because as you alluded, and your dad mentioned to me, and you'll hear many pediatricians tell you the same thing in the emergency room and in the office. We're overwhelmed with kids with anxiety, depression, kids who want to commit suicide. It seems like the last 3 years have been extremely stressful for society as a whole. And you've done some research on how to prevent some, if not all, of these suicides. What would you like to share with us today?
What I'd like to share is that there is a low-cost, scalable approach to, increasing secure firearm storage in homes, which is a universal prevention strategy for suicide. So I'm just going to give a little bit of background because I think it's helpful context. So we know in the US, 1 in 3 homes have a firearm, and those numbers have actually increased in COVID and the civil unrest that's followed. A lot of people are buying guns that don't necessarily have a background in firearm safety. And so we know that there's a lot of guns in homes. We also know that the suicide rate in our country has unfortunately been increasing over the past decade. It's been increasing most steeply in minoritized and marginalized communities. And we know that firearms are the most lethal method of attempt. So over 90% of young people who attempt with a firearm die. which is not true of other mechanisms. And so there's been some great simulation model work that's shown that if more firearms were stored securely, that we could prevent up to 32% of firearm deaths. We also know, and this paper just came out this last year, actually, that firearms are now the leading cause of death in young people in the United States. And so there's this very simple program that was developed by Dr. Sary Beidas and colleagues at Vanderbilt and tested in a large pragmatic trial in lots of pediatricians' offices. And it was a more involved than just firearm focused. We've been focusing in on the firearm component. It's called the safety check. And it basically included screening for firearms in the house, having a brief discussion between the pediatrician and the parent about the importance of secure storage, and offering a free cable lock. That trial demonstrated that intervention resulted in more secure firearm storage. There's also been other studies done that show that secure firearm storage are related to decreased deaths. And so we took that program, the safety check, we adapted it, and in partnership with firearm owning parents, with clinicians, and we've renamed it Safe Firearm. And now it just is comprised of actually just having that brief conversation and offering cable locks to all parents, and really focusing it in on universal suicide prevention. The initial study was really focused on unintentional injury in young kids. So we're now doing a 30 clinic trial in Michigan and Colorado, where we're testing changing the electronic health record well-child visit template to have a prompt around the program. Doing that for all clinics. And then half the clinics are also getting something called facilitation, which is a PEDS or primary care practice implementation strategy to support them in incorporating a new practice into their clinic. So half the clinics will just get the nudge in the EHR and half will get the nudge plus facilitation. And hopefully at the end of the trial, we'll be able to advise health systems on which approach might be most effective at implementing this program in their health systems. At the end of the day, if that's all too complicated, have a conversation with your patients and their parents about secure firearm storage. If you can access cable locks and give them out for free as a safety device, do so. There's a lot of organizations that are now making them available for free. You could partner with them or with your local police station, and you could save a life. Unfortunately, firearms account for a large proportion of suicide deaths. And what we want to do is put time and space in between feelings of suicidal ideation or a suicidal plan and having access to means, because we know that once a little bit of time passes, those feelings pass. And unfortunately, if someone has access to a firearm in that time, the likelihood of them dying is very high.
So I was very interested that one of your focus groups was gun owners or people who had to use guns at work. What did you find out when you did those focus groups?
Yes, we did some interviews with various stakeholders, including firearm owners, including people who are firearm safety course instructors. What I have found is that the firearm community has been tremendously welcoming to me and my research team in partnering around a shared mission to keep young kids safe. And that firearm owners and firearm safety course instructors want to ensure that pediatricians have this conversation in a non-judgmental, respectful way, acknowledging Second Amendment rights, and also that nobody wants their kid to not be safe, and that we're all on the same page about that. And so there's a lot of discourse about, firearm rights in our country. This is not about that. This is just about keeping kids safe. And if you can stay grounded in that and kind of continue returning to that, and have a conversation in a non-judgmental, respectful way, people feel really good about pediatricians providing anticipatory guidance on this topic, just like they do on all kinds of other things. I actually had this light bulb moment. My young child and I were at the pediatrician's office, and they were asking me all these questions about car seats and smoke alarms, and they never asked me if I had a firearm or if I stored it securely. That's an opportunity to save a life.
Great. And you also said something that I really appreciated on your YouTube talk. You said when it's issues that are very divisive like this, we need to keep politics out of it. Why is that so important?
Podcast, Herb. But I think it's all about that shared mission and coming together around something we can all agree upon. I think often politics then put us in a kind of us versus them scenario. And so, again, our team, our partners, we all agree that we want young kids safe, happy, healthy, and alive. And that's all that matters. It's none of that other stuff enters into these conversations.
Yes, that's very important. George, I wonder, do most of the practice in the CIN ask about gun ownership, or is not an issue in Long Island?
I'm sure it's an issue somewhere in Long Island. I'm not sure if people ask about it directly. I'm sure we have a lot of police officers and detectives. I don't know. I don't think so.
Yeah. I used to have FBI agents that came to the urgent care, and they always had the gun either in their purse or in their hip. That they never leave the house without it.
Yeah.
Sady, I'm very concerned about all these, and Rinad mentioned this, all these non-evidence-based practices in the area of med tech or apps or app-like things that are popping up. I think the worst was Cerebral, that was prescribing Adderall, Xanax, Ativan to anyone who called for any reason. There's others out there. For example, there's one that keeps popping up on my Instagram feed about attention deficit disorder coaches. They're not therapists. There's no data behind it. There's another one that is using child life specialists to help your child in the event of a mental health crisis for $175 for a 45-minute video call. We already have a disaster of mental illness in this country. We don't have the right resources. We have a lot of shame, or people don't want to, they're embarrassed that they have anxiety or depression. And we're not using best practices. How do we elevate the tech that may be helpful and change the world, while walk away from these other things that may be harmful to society as a whole?
Yeah, I think, Herb, that anytime you have a new technology that comes in, there's a learning period that people go through. And we may, just like in the Industrial Revolution over 100 years ago, initially, a lot of things were going wrong. For example, a lot of workers used to die or get injured, secondary to the new, all the new stuff that was industrially built, but without the safety nets into making sure that an instrument does not take a worker's arm, all the occupational hazards that were associated with it. And I think with this information age, we kind of are going through the same thing. We're still early into it. Although maybe 30, 40 years sounds like it's a long time, but it's actually, we're still in a learning phase. And these apps, the iPhone only became available in 2007. So it's barely, 15 years ago. So I think a lot of people will continue on developing stuff until we have a clear understanding, and until you have sufficient regulatory oversight for developing things that patients may use. I wish this was done earlier, but again, just like Rinad said, everything we do is downstream rather than upstream, where we should have developed the processes to prevent these things in the first place from happening. They shouldn't have come to the market in the first place before they're actually associated with trials that show that they're useful for human beings.
Yeah, it's it's a problem. It's a problem because uh, people are not literate in healthcare, less so in mental health, and they're looking for a solution, and an app pops up, and they may waste a lot of money, and worse yet, they might end up with a poor outcome.
That's where the doctor comes in, the relationship with the patient to tell them you should do this, or you should not do this.
Yeah,
Doctors cannot be replaced by a computer app. I don't care what anybody tells me.
no, it's not
We all
possible.
agree on that.
Not possible.
I don't think the tech world does.
I think that
I'm with you,
tech
George. I don't think they realize that too. They think it's a fast bullet that will solve the whole problem.
Yeah.
It makes them money perhaps, or there's some other monetizing incentives.
Well, that's what it is, monetizing incentives that they're interested in and moving on to the next one.
So I tend to be a little critical and pessimistic, if you haven't noticed. So what optimistic notes do we want to end this podcast on, Sady? What do you think with bright in the future?
I think that it's wonderful that there's this something that's called implementation, because when I started and used to implement things, you know, whether it's the electronic medical record or all the other technology that comes in, we were doing it without really understanding how to do it. You know, we just do it locally, but when I wanted to do it in another place, you would fail. And so the scaling piece, I'm very happy that there's this implementation science that's come in and has made it a rigorous exercise in academics to really understand how we should go ahead and, you know, change things for physicians and for others as well. Yeah.
Great. How about you? What do you think, Rinad? What do you think you're optimistic about the future?
So I kind of think implementation science is baked into my DNA. I remember my dad talking about his experiences as a physician when I was very young. And you know, you wanted me to be an MD, but I think this worked out.
I think so.
But I remember really thinking about the importance of equitable, easy to access healthcare. I even wrote a poem when I think I was 10, called Insurance Please. And so I feel optimistic about this opportunity to be on a podcast with my dad and to continue to learn from him. You know, I really love that analogy you gave of the Industrial Revolution, and also the future of my children and what they might do in healthcare or whatever they choose in the future. Kids are our future, and I'm glad to see a podcast focused on kids and relationships and rebuilding after a couple of really difficult years.
How about you, George? What are you really optimistic about?
Oh, I was afraid you were going to ask me that. Well, I guess what saddens me is I speak to a lot of physicians, and when they ask them, should my kid go to medical school, they say no. That saddens me a lot. My son is in medical school. I believe in physicians. I believe in private enterprise, private practice. And I think I'm becoming a dinosaur. I think the technology companies are trying to replace the physician. I think the MBAs are trying to do things that, you know, the business people in the hospitals and in the universities are trying to replace the physician with lower pay, you know, providers. I think, you know, the academic people, they're good people. Somebody has to do research because I can't. But I think the researchers need to have a rude awakening of what a physician-patient relationship is. You know, I'll give you an example. They just changed all the Bright Futures developmental screening things, questionnaires. Very complicated, very cumbersome. I'm wondering whether half the people use it anymore, where the old one was perfectly fine.
No thought about implementation.
No,
Or how
they just throw a bunch of words.
That's right.
They just throw a bunch of words in a computer, and they think that the computer is going to grade it. And, you know,
or if it's useful to the patient, or how the customer, who is the parent in our it perceives that? Is it any value to them? Because half the time when I cover somebody's practice, I go like, why am I filling all these forms? My
Yeah.
kid's healthy.
Yeah. So
You
you have to know
know,
when to use it and when not to use it,
that's right.
you know.
So
And I think a lot of people are trying to replace that physician person. You know, I'll give you a great analogy. I was speaking with a friend of mine. I play in a band, right? One of the guys was a tech support guy. He fixed computers. And I had asked him about I had a hard drive that crashed, and I looked on YouTube, said if you put it in the freezer and you make it cold, and then you connect it to this hub, you can do this, and then you can take the data off of the thing and put it onto another computer. And I told him that story. He says, yeah, you can do that. I said, so why does your job exist? Because I just looked it up on YouTube. You know what his answer to me was? Because I'm the guy that pushes enter and told you can do that. That's your doctor. Okay.
Yeah. Well,
So it's interesting, right?
yes.
That's
So,
what I'm the guy that pushes enter and tells you, don't worry. Or I'm the guy that tells you, you really should worry.
so when I see Rinad and Sary, it reminds me of why I became a pediatrician. And basically, I was taught a child is a blank canvas. You don't know what they will be. They may be the person that takes care of your cancer as you're dying, or they may be the person that becomes the next president of the United States, or they may just be a phenomenal parent. So when I see a really good friend like Sary, and then I see his daughter blossom into this great researcher with 200 publications and $31 million in grant money, and at the young age of hers, already chair of a department, it fills my heart with gratitude that I have been able to have this friendship with your dad, and that I saw you as a little child, and that I've seen your own child, and that through all this time we've been able to use technology to remain friends, and that is a great gift in my life. And as well as George has been a new friend, but is a great gift in my life, and that fills me with great joy and pleasure every day. And I wanted to thank all three of you for that, and for being part of this experiment where we have conversations and we build relationships, and we say what's great about what we do for humanity as a community. So thank you very much to the three of you.
Thank you.
Herb.
Thanks for
This has
having
been a
us.
fantastic opportunity to be with you. And, you know, this is the first successful, what should I say, endeavor that Rinad and I do together. Years ago, maybe 10 years ago, I kind of wrote a paper and wanted her to help me
I
with it.
tried to fix it.
That's right. And
You couldn't get it over the
I
finish
couldn't
line.
get it right. That's the problem. And so thank you for bringing us together to do that today.
Thank you for taking time off of your vacation at Cape May,
Of course, sir.
and hugs and kisses to Amal and the children and your husband.
Thank you.
And George, I would love to chat more. What you're doing is fascinating, and could be really interesting partnership. I love hearing about great work like the work you're leading. So keep it up.
Great.
Thanks, guys.
Thank